Today we'll start to look at our respiratory physiology and look at the mechanics of respiration as we begin here. So in terms of the respiratory system, just a quick review, we have the passages here of getting air into the respiratory system. So we run through the nasal cavity, down in through the pharynx and into the larynx. The mouth can also be used, but primarily we talk about the nasal passages as being that for respiration. Move down into the pharynx, we get a combination of both eating as well as air moving through, so there's food and air. Move in towards the larynx, and we've got our epiglottis there to switch us between the esophagus and the trachea so that we can move things down and through. Then we run through the trachea down into the first part of the bronchial tree here, move into our primary bronchi, and that's going to split us through the carina into either lung, and then we're going to split from there into secondary and then tertiary, and then down into all of our little bronchioles as we get further and further down in, eventually into the terminal bronchioles and the respiratory bronchioles, and all the way up until that point of the bronchioles, we've been in the anatomical dead space. And so we've been simply in the airway passages for air movement, but not for gas exchange. Now that we're down into the bronchioles, we can start to do gas exchange primarily occurring in the alveoli themselves. So in those alveoli, we have the mechanisms for gas exchange. We have a huge surface area of the individual alveoli, making some 60 square meters or so of space throughout the entire lungs, and then a vast network of capillaries. And so those capillaries are where we're going to do our gas exchange between the alveoli and the lungs for our external respiration and allowing for that exchange to occur. In this case, we have to remember that in terms of those capillaries coming in, the artery side of the system, so the arterial side, is going to be a oxygen deficient side, but the vein side is going to be an oxygen rich side. So we're picking up oxygen here from the lungs and carrying it back towards the heart. So it's going to be in a vein as it does so. With this process, we're going to have a series of exchanges that occur. And so the first exchange itself is going to occur in the lungs as we move things in. And so air containing high amounts of oxygen is coming in. And so we'll have an exchange of oxygen and carbon dioxide. Oxygen comes in, gets transferred into the alveoli. From those alveoli, goes through the pulmonary veins back to the heart. And then the blood is going to be transported to the tissues. And then at the tissues, we're going to drop off oxygen and pick up carbon dioxide. And so the oxygen is headed out towards the tissues. Carbon dioxide is going to be picked up into the capillaries in the tissues. And then we're going to start to head back towards the lungs with that. And so move back in through the veins, get us back into the right side of the heart. And then from the right side of the heart, move through our pulmonary arteries out towards the lungs, and then do gas exchange there again. And so now the carbon dioxide is going to be moving out. Carbon dioxide levels are going to increase inside those alveoli. O2 levels are going to decrease inside the alveoli, and the exchange has now occurred. We've now done our external respiration. We did our internal respiration over here in the systemic tissues. And so that's where we've done that process there. So how do we actually get breathing to occur? What's this whole process itself? And so in order for breathing to occur, we have to have inspiration. So we have to get air into the lungs. The primary process for this to occur is via the diaphragm. And so the diaphragm is going to be our primary muscle that's going to be utilized in order to change the size of the thoracic cavity. And as the thoracic cavity becomes larger, the pressure inside the lungs themselves starts to fall. And so it's going to drop there. As we now have a pressure gradient outside of the body, we have a high pressure. Inside the body, inside the alveoli, we have a low pressure. That's going to allow for air to now flow along that pressure gradient. And it's going to go from an area of high pressure towards an area of low pressure. And so we're going to get that pressure moving into the lungs themselves. And now we have the inspiratory process occurring. And so atmospheric pressure, typically going to be somewhere in the neighborhood of about 760 millimeters of mercury. And as we have that pressure inside surrounding our bodies themselves, in order to get the lung to come into the air to come into the lungs, we've got to lower the pressure inside the thoracic cavity. This occurs by the diaphragm depressing. And so the diaphragm is going to move downward. That's going to increase the space inside the thoracic cavity and thereby decreasing the pressure inside. And so now that pressure inside there's going to be somewhere in the neighborhood of 756 millimeters. So we're going to go down that pressure gradient and the air is going to move into our lungs. As it does so, we now have a period of time where essentially we hold our breath, and at that time the pressure inside the lungs is going to be 760, pressure outside is going to be 760, so there's going to be no air movement. But as soon as we start to elevate that diaphragm once again, that causes the thoracic cavity to start to become smaller, and as that occurs, now our pressure inside the lungs is going to go up somewhere above 760, and now the air is going to move back out. And so we've got a pressure of just 1 millimeter difference, and that's enough to get the air to start to move out. If we make that pressure even greater, and so move the pressure inside here to say 764, now we're going to force that air out with even greater force. We can do things like sneeze, cough, to clear the airways themselves. And so the expiratory process itself is essentially just relaxation. So there's not a whole lot of active muscle contraction that is needed for normal restful breathing. And so it's simply the diaphragm relaxes, the elastic recoil of the lung tissue of the chest cavity falls down in a sense. Gravity starts to pull it down, so the chest cavity becomes smaller. Think of the lungs themselves in terms of this elastic recoil as being something similar to a balloon. You blow that balloon up and it stretches out and pushes out on the rubber of the balloon itself, and the air is pushing out inside, but at the same time the balloon is pushing in, and so all of that elasticity is pushing in, and the force of the elasticity is greater than that of the air pushing out. And so now all of the air that was inside now is going to start to blow out, and our balloon can kind of blow up all across the room, versus our lungs, which are just simply going to deflate. And so they're going to decrease the pressure that is there. And so now we have a high pressure inside the balloon or our lungs and a low pressure outside. So that's going to force the air out. And now we have expiration. This whole process itself we can measure, and we can do this in the lab and look at the volumes that we can create. And in anatomy, we looked at this process as far as where those volumes were and what those volumes were. But in the lab, we're going to actually look and see how they change with different activities and things like that as well. And so with normal restful breathing, we have what we call the tidal volume. And so that tidal volume is going to be somewhere around 500 milliliters or so. And that's going to go up and down and up and down. But then we also have some extra abilities in a sense. And so as we blow out a normal exhalation, with the next breath in, if we force all the air in that we can, this is what we're going to have as our inspiratory capacity. And so this is going to be the amount of air from a normal breath in to full inspiration that we have. If we were to just take it from a normal breath and then go all the way up to a full inspiration, we would have the inspiratory reserve. And so the inspiratory reserve is that extra amount of air that we can get in that is on top of our normal inspiration. And so that number is going to be somewhere around 3,000 milliliters, or 3 liters is that extra amount that is there. And so then we breathe it all the way out. So now after a normal inspiration, if we then do a full expiration, blow everything out that we absolutely can, this is going to give us another set of extra components that are there. And so we're going to have now our expiratory reserve. And so that's that amount from a normal expiration to full expiration. This one's a little bit less, somewhere around the neighborhood of 1,200 milliliters or so. And so this is the amount that we can expire is a little bit more. But you'll notice that we don't actually expire all of the air. There's always some air still available inside the lungs. We have that residual volume that is there. And that residual volume is what kind of primes the lungs to stay open. And so it's not going to be completely deflated after we do a full expiration. From that very point there where we have full expiration, if rather than just going up to normal inspiration, if we then inspired everything that we had and everything that we could get back into the lungs, we would have what we call the vital capacity. And so the vital capacity is the amount of air that we basically can exchange at any given time. And that's going to be somewhere around 5,000 milliliters or 5 liters. The total capacity is going to be somewhere in the neighborhood of 6 liters total. And so that's going to include our residual volume, our expiratory reserve, our tidal volume, our inspiratory reserve, everything that we have available for inspiration and expiration. So everything that's there is our total lung capacity. So we can move that air in and out, and the differences in terms of the pressures come from a couple of different things. And so we have different pressures that are active at any given time. So we have the atmospheric pressure. This is somewhere in the neighborhood of 760 millimeters of mercury at sea level. So it's going to change just a little bit depending upon where we are in terms of altitude and things like that. So pushing down on this little guy here, we have 760 millimeters of mercury of pressure in the air itself. In order for him to get air to go into his lungs, that pressure that is inside his chest, we have an intrapulmonary pressure and we have an intrapleural pressure. The intrapulmonary pressure is the pressure essentially inside the lungs, or more specifically inside the alveoli. And so this is the pressure that we have inside there. And in order air to come in there, we're going to have to start to lower that pressure down. So 756, say. The intrapleural pressure is the pressure in between the thoracic wall and the lungs. So it's in between the wall and the lung itself. And so the pressure that is in between there is always going to be slightly lower. So maybe 754 in terms of the pressure that's there. And so that pressure is the pressure that's essentially going to allow the chest wall and the lung to help to move in one movement. And so as that chest wall moves outward as we start to breathe in, that's going to lower the pressure here in the intrapleural pressure. And so we're going to have a low pressure here, a higher pressure here, and so that's going to pull the lung in towards the wall itself. That's then going to lower the pressure inside the intrapulmonary pressure. Intrapulmonary pressure is now lower, and so air starts to rush into the system. So atmospheric pressure versus that of our pressures inside our intrapleural and intrapulmonary pressures are going to change. So if we're holding our breath, and so if there's nothing going on in terms of air movement, that pressure inside the lungs is going to equal that of atmospheric pressure. So in this particular case, we've just exhaled. So we've just done expiration. And now our pressure is 760 on the inside and 760 on the outside. But you'll notice that the intrapleural pressure is still lower than the two. It's always going to be lower than that of either atmospheric pressure or intrapulmonary pressure. The two of those are always going to never equal one another. If they do equal, and we'll talk about this in just a moment, then in a sense, kind of bad things happen. So as we go to take a breath in, we've got 760 millimeters, 760 millimeters. There's no air moving in at all because our pressures are equal. So we're going to have no change in pressures whatsoever. But as we start to do inspiration, we're going to lower that pressure in the intrapulmonary pressure. That pressure inside the lungs has now decreased. It's lower than that of atmospheric pressure, and so air is going to start to move into the inside of the lungs. That pressure is now able to be overcome and it gets pulled into the lungs themselves. Intrapleural pressure is still going to be below that of intrapulmonary pressure. For expiration, we've now got to raise that pressure inside the lungs, and so we've got to raise our intrapulmonary pressure up. So that's now going to increase inside the thorax, and so our intrapulmonary pressure is going to be increased. That's going to force the air out of the lungs themselves. The intrapleural pressure, or I'm sorry, the intrapleural pressure, is now going to still be lower than that of intrapulmonary pressure. And so we have now a decrease in the size of the thorax. That causes an increase in the pressure, but we still have a differential between that of the intrapleural and intrapulmonary pressures. The intrapleural is still lower than that of intrapulmonary pressure. That's there. We need to have that pressure always lower. And so we always have to have this intrapulmonary pressure and intrapleural pressure never equaling one another. If that should happen to occur, then the lung is basically not going to stick to the thoracic wall, and the lung is going to start to collapse. We're going to get what we call atelectasis. And so the lung is going to collapse down if we don't have that there. In between, in that intrapleural space, there's a tiny bit of fluid. And so we've got a tiny, tiny little bit of fluid there. Remember back to fluids in the past in terms of the respiratory system in anatomy, that in a sense when we have two spaces next to one another, and if there's a little bit of water in between the two sides are going to be attracted to one another. They're going to be kind of stuck together. And so that's what we're relying upon here to kind of keep the lungs inflated, to make them stick towards the outer walls themselves so that they don't become deflated. If we should somehow cause the pressures to become equalized, and typically this is going to become coming from some sort of pressure puncture wound, and that puncture wound is typically going to be in the thoracic wall, but it could also come from something happening to the lung. And so when somebody has something like pneumonia, somebody has a bad cough, things like that, they can start to develop what's called a little bleb, and it's kind of like a little bubble on the surface in the visceral pleura that's there. And as that visceral pleura starts to expel air, it creates a greater and greater space inside here. And so our pressure, our air pressure is no longer being maintained the way that it normally should. And so if something should happen to equalize that pressure, now our lung is going to have the same pressure outside. And so our atmospheric pressure, our intrapleural pressure, and our intrapulmonary pressure are all going to be equal to one another. And that's going to cause that collapsing of the lung, or that atelectasis that is there. And so all of the pressures are the same. On the other side, since the heart and the lungs are all contained separately from one another, that's going to leave a situation where the other lung can still function. The person's going to have a very difficult time breathing. They're going to have a large amount of difficulty there, so they'll have a significant dyspnea as far as their ability to breathe and so on. They're not going to be well oxygenated the way that they normally should, but they're at least able to continue to breathe. As soon as we plug that hole, stitch things back up, get the chest wall filled there. If the lung had any damage into it, stitch that up, and now we can then reinflate the lung, and it's going to reinflate and refill the space that's inside there, and that's going to allow the lung to then start to function normally once again. Next up, we'll talk about the compliance of the lungs and their ability to expand and contract as we breathe in and out.